So I want to thank, first of all, the organizers for inviting me to present this topic, for which I'm actually quite passionate about as well. And obviously now I have to present after Ben, so no pressure, obviously, for this presentation. So yeah, I come from Montreal, University of Montreal, Sainte-Justine, and I'm going to dive right in to talk a little bit about outreach, specifically outreach simulation. So we'll get a bit into it. Let's start with this picture. And what I want all of you guys to picture here is that you're approaching this scene from the outside. You're basically, imagine there's a child who's on this pavement, and you're a first responder. You're there at the site of the accident, and you're going to have to intervene. You're going to have to do something to help this child who's there. The child is maybe 6, 7 years old, and I know the majority of you are neonatologists. So take a few seconds to try to think about what you're feeling at this moment in time. So it's probably some mixture of anxiety, some drive to actually go ahead and act and help this child, maybe some fear as well. But you're trying to remember some of that stuff you remember from your trauma, rotations back in medical school that's really far out because we don't see much of that in neonatology. So let's try a different scenario here where now you're in a plane and you're with a colleague of yours who's a pilot who dragged you on this plane, unfortunately. And now this colleague of yours has a medical event. And you're going to have to actually fly this plane and land it at this point in time. So now how are you feeling? Take a few seconds and try to think about how you're feeling. So probably you're lost at this point in time, and unfortunately what's going to happen is that, let's just see if it's going to work. What's going to happen, unfortunately, is that this plane is going to crash, right? And the reason why it's going to crash is because you have no backgrounds in anything related to flying, unless you are a pilot, and for that, that's great. But if you don't, then it's basically going to crash. And why is so if I were to ask you guys which of the scenarios you want to choose, probably be scenario 1 over scenario 2. Probably because you have some background there to go back to, some training, ABCs, trauma, C-spine, all that stuff. You just got to go get it. It's way back. And of course, pilots, they need to go through training. They have to go through regular training to get where they're at, just like we do. And they're very stringent for essentially being in command of an aircraft. They need to have some rules will say that they have to have had 3 successful landings and 3 successful takeoffs within 90 days to command an aircraft. So that's something that's, I don't know if I've thought about that. Does a pediatrician need to be having 3 successful resusces in the last 90 days to be in command of a resuscitation? That really doesn't really exist. And of course, that brings us to the core topic of today, which is basically a surprise newborn that will be born in a community center, such as this premature baby. And the core difference here is that the end user here, which is the parents of this baby, when they come to a community center and they deliver this baby, they have an expectation of competence from the team. They don't know all the stuff that we know. They just say, okay, I'm going to deliver a baby, and I'm going to expect this baby to be well taken care of and healthy and all that. The question then is this community team ready? Is this community team competent enough to manage this baby? And when I think about competence, I always picture myself watching these ads about drugs, often when we come to the States, because in Canada we don't have lots of ads about drugs. And it ends with some long IMAB or whatever, and then after that, it says right at the end, consult your medical professional. And then I tell myself, well, I'm a medical professional. How is it possible that I don't know what's this drug, IMAB or whatever? And so it really makes me question my competence. I know it's all about legal stuff and it's just put there for that reason, but it does, prove that point. And so there is a certain expectation of competence, right? So if somebody's going to go to a garage, they're going to bring their car, they're going to want that garages to fix their car properly, orderly, everything is going to be nicely done. They're not going to want that garages to sort of sift around through, that Cars for Dummies, book and sort of figure out how to fix their car. And you might tell me, of course, it's not fair to compare a physician who's going to be taking care of a very sick newborn to garages, and you're right. You are right. Because, in fact, when you're dealing with these sick newborns, there's a lot of stress, which the garage is not necessarily dealing with. And the garages will see these things over and over again, whereas a pediatrician or a family physician will not see these things on a day-in, day-out basis. So what I'm trying to emphasize here is that competence is really something that is very dynamic. That's a really key thing that I want to emphasize for when we talk about neonatal outreach. And this concept is really exemplified in this study, where they found that most pediatricians did not maintain their skills throughout their professional practice, including things such as PPV, and of course not intubation and things like this, just general resuscitation skills. And when you put this within the context of deregionalization, that is lots of NICUs that have sprouted around big city areas, you realize that there's a lot of dilution, what we call dilution of expertise in these different centers. And this is an article I found as well in Pediatrics in 2016, and they looked at almost the counties in the United States. Nearly half of all the counties in the States are without a general pediatrician. 82% actually lack one in a rural area. And what's even more telling is that the hospitals that have a low obstetric volume actually will have higher rates of birth asphyxia. And this was actually exemplified in a recent abstract that I saw at PAS and IMSH, which is a simulation conference, which a group out of Maine, which looked at the impact of birth volume on neonatal resuscitation practices in neonates that were treated with therapeutic hypothermia. What did they find is that in the low volume centers, there was more chest compressions and it took longer to get established an actual definitive airway. So there are probably some deficiencies there in neonatal resuscitation, so they probably have the greatest need. And of course, we know that the volume does impact also outcomes for premature newborns. Nothing is new. You guys all know this. You guys treat inborns, outborns all the time, so that's nothing new to anyone. So people have said, why don't we just, bring back the kids, bring back those sick kids. Well, that's actually done, and that's great. We do have maternal transfers. A lot of work being done in outreach for maternal transfers and getting them quicker to the level 3, level 4 center so we can take care of that baby. But, some of these things are surprise births, the surprise uterine rupture, the surprise 25-weeker. And so this was a nice quote where it said there are regions where centralization of obstetric and neonatal care is not feasible, and we should focus on equipping these hospitals with staff, training, and more resources to provide high-quality obstetric/neonatal care in the absence of high patient volume. So there really is this gap between the community center and the academic center, and that's where the term neonatal outreach can have an impact. And so I provide you this definition today of neonatal outreach, which is training that actually occurs in a community hospital, which is supported by a curriculum addressing a wide range of topics, allowing academic centers to share their expertise with community medical center partners with an emphasis on simulation. And why are these community centers having these difficulties? Well, there's of course the issues we mentioned about volume. There's some issues sometimes related to equipment. Crisis resource management. I know Dr. Kumar talked a little bit about this yesterday. It's a very simulation term where we're going to talk a little bit about communication, leadership, situational awareness, roles. Sometimes there's a lack of regular training. This has come up in many talks. Who are the champions at the local sites to take care of this training? There's often missing these champions. And there's a lack of knowledge as well. And the core concept here I'm getting at is emergency preparedness. What is the emergency preparedness of these community centers to accept or to have a really sick newborn deliver haphazardly? And that is the degree to which a system and an individual are ready to handle aspects of emergency care. In pediatrics, not neonatology, but in pediatrics, they've been looking at this quite a lot in the last 15 or so years. So there were guidelines that came out for how you should be managing a pediatric patient in an emergency department. So a group of researchers actually did an assessment of all pediatric emergency departments, looking at how ready were they, looking at census, looking at equipment, looking at personnel, and they published this on a very macro scale. And there's some researchers that also looked at this on a very granular micro scale. So here they looked at, how are these EDs performing in certain pediatric resuscitations, such as status epilepticus and cardiac arrest. And they were able to show that, of course, the pediatric EDs outperformed the general EDs. But the great thing about this study is that they provided each of those emergency departments with key, bulletin points to work on in report card afterwards, which were related to all kinds of things, whether it was equipment, knowledge, personnel, and so on. On top of that, they were able to show that, this group was able to show that over 6 months of accompanying these emergency departments, they were able to improve their pediatric readiness. But of course, we're at a NICU conference, so let's talk a little about babies. Is there anything that we can say about babies with regards to this topic of emergency preparedness? Well, the good news is that in 2023, the American Academy of Pediatrics did publish standards for the levels of neonatal care. I'm not talking about the definitions of like what a 2, 3, 4 should be. This is actually standards including personnel, census, equipment, all those things that have been published. So we can now benchmark the performance of units based on these standards. That I don't think that work, as far as what I scanned the literature, has not been done yet. Most of what's been done actually has been very minimal to looking at how prepared are units for accepting this sick newborn. Looking at perhaps rural Canadian emergency departments. There's been a lot of work out of in Africa and Nigeria, Ethiopia, a lot of studies published there, not much in our area in North America. So what's actually described mostly is these descriptive studies of what these programs of neonatal outreach simulation are like. So here we have Dr. Byrne, who had the pleasure of meeting actually, who actually is from Indiana, and Dr. Manas, who's a colleague from Vancouver, who describe their outreach simulation programs, their curriculum, their learners, the challenges they faced, how to get it going. So that's a very interesting one. And they've been publishing a little bit, so that's how I got to know a little bit about these individuals. And I'm sure there's even people probably here in this room that do a lot of outreach and maybe hasn't shared some of their work. So here they show that the simulation they do in the Indiana network improved a thermoregulation for preterm infants. And there's also this group out of Maine, which I've been also getting in contact with, which is doing regular simulation outreach with their teams, showing it improves their confidence in neonatal resuscitation, and the study I just showed you as well is one that they showed. But I want to emphasize that, I think like the first speaker had mentioned, these are not new concepts. It's almost like we're always going back to these concepts. This was actually from 1989, talking about how community hospitals can be accompanied by academic health center. And then it kind of, like in the first speaker said, it died off. So, and now we're getting back up there. And the thing, I think what's most important there is really sharing what we do, because like I said, a lot of you are doing this work, but we're just not sharing it enough. So that's what I'm going to do next. I'm going to talk to you a little bit about our program, our neonatal outreach program that we've come up with, that we've developed since 2021. And the reason why I want to present this to you guys is just to kind of give you a blueprint of what we did. And if some of you are interested in doing this as well, or developing this further in your centers, or if you've developed it further and you want to give me some pointers, that's actually great as well. So the goal of the program really is to optimize the care of newborns in our community centers, in our catchment area. And what we do, we review complex neonatal transports that they will come and tell us. We'll do simulation days with community centers. We'll have teaching modules, and of course it's accredited. What will happen is that we'll circulate a brochure to each of the centers, and this brochure will be empty by design. We don't include set topics anytime we go out to these centers, because each one will have their own needs, some variation of which. So I will always have a meeting with the nurse managers, always have a meeting with the physician who is in charge, and discuss what are these over Zoom many months before the meeting. And we discuss what are the topics we're going to go ahead. So maybe it's going to be pneumothorax because they had a really, really bad pneumothorax. Or it could be asphyxia because they had one case that did really poorly, or seizures, whatever. So we include that in the case discussion. It's always multidisciplinary. And then the sims, heavy emphasis on simulations, which are always done in situ, which if some of you were with Dr. Kumar yesterday, you guys know in situ means in the actual care environment where they're actually going to be practicing. And so far to date, we've trained about 450 professionals, which is only a drop in the bucket, looking at some other national outreach programs like in the United States since 2021. We've done 24 training days, almost the entirety of our catchment areas, of our catchment hospitals of our tertiary care center, half of which are nurses, about 15% RT, and 35% physicians, a mixture of family doc, peds, anesthesia, even emergency physicians. And that is pertinent to remember because a lot of these centers, the pediatrician is not the one who's going to attend the delivery of these babies, especially if it's at night, because they have to call them in 20, 30 minutes later. So often when we do these days, it's going to be the emergency docs who are in the emergency room coming up, responding to the code pink that's happening in the L&D. Just a few pictures of where we're doing. So this is an example of like our in-situ work. So we're always, this is like a resuscitation bay where we're working there. And on the bottom right, you can see we're in L&D. And everything is done with the equipment of the team. If sometimes it did happen once or twice where there was an actual emergency, we had to reel out really quickly. So we have checklists for this, just to make sure everything is safe, to make sure we can actually reel out with the team if there's an actual emergency. And on the right picture there, you can actually see that we're doing these are actual just modules, specific training modules for chest tubes, sometimes surfactant delivery, how to just fix an endotracheal to be surprised. All these little basic things that are extremely important for these community teams, even basic ventilator settings and such. And if we need to go to the OR, we go to the OR. And sometimes the OR seems to be a critical area because the anesthetist will always be there. So how do you interact with the multiple conflicting leadership of anesthesia, pediatrics, or family medicine? So it's a really interesting venue for us to go and do these things. And of course, we're also doing the training days, the case discussions. This was just last month where we actually went in and did this case discussion with the team. Very fruitful, multidisciplinary. So initially, the program, when we launched it, it was self-funded. I was buying gift cards. kind of ridiculous. And people were saying, you're crazy, you're gonna have to charge these centers. There's no way it's gonna work if you don't charge these centers and have them pay for their training. But I really didn't believe in that. I trained out in Alberta, which had a Kids Sim provincial program, and I was participating in the outreach for pediatric trauma, and the centers never paid a thing. And I think it was really key to getting the centers hooked and really continuing the training. And so what happened is that I kind of identified one or two champions, actually more than that, 2 or 3 champions, one RT in transport, one RN in transport, who are really passionate about education, natural leaders, and nurse practitioners who were able to thankfully include this within their research work hours, because I could have never have afforded that. And this team, which I'm going to show you next slide, is the one that has been with me pretty much throughout the whole outreach. So we have 2 nurse practitioners, 1 transport RT, 1 transport RN. So we kind of regularly convene as well after outreach days to sort of talk about how we can improve it and improve the program. And like Dr. Kumar mentioned yesterday, a lot of what we do is very low tech, just simple equipment, basic low-fidelity mannequins, an iPad, an iPhone, project the vitals with a free app, NRP Vitals. So that's you don't need much actually to get the buy-in and for the project. So once we had proof of concept, after 6 or 7 sites, we approached our Department of Education for a pilot grant, which we got for 3 years. And with that, we were able to recruit additional faculty. Most of the transport team members now on our team actually go out and will go for training in these different sites. And I think that's really important to have transport team members go there, because they're the faces they're seeing when they're going to get these babies in the community centers. We're able to actually afford to buy a Sim Newbie high-fidelity mannequin as well, administrative help, and development of a website. And now we're slowly thinking about transitioning to fee-for-service, because we don't have that grant going along. But it's really just to cover, simple costs for the personnel, pricing in probably between 800 to 1,000 Canadian dollars, for an outreach day, which is honestly not that much when you consider all the training that's going on. And we've also now have nursing and physician champions at each site, which we regularly meet. And I also had the opportunity, I guess the honor to continue this conference that we organize year by year, which is a conference for pediatricians in our community. And this helps also fund more things into our outreach program. And from an academic perspective, we've also been working on trying to get some papers out there, research out there, looking at, for instance, what are the needs of our community teams, looking at resuscitation that's going on, in the delivery room, and even specific conditions like bilious vomiting. That's something that really holds to my heart. The bilious vomiting, babies who have bilious vomiting, how we can get them quickly to treatment. So we're trying to get a little bit involved in these different elements of trying to get our work out there. And what I will just share with you is just this needs assessment is really important, because that helps shape our curriculum. There was really 8 key things that came out of this needs assessment for how we should develop an outreach curriculum for our community teams. Number 1 is they want procedural training. That's key. They always, they want to get trained with PPV, intubations, UVCs, PIVs. So procedural training is really critically important. Stress management is something I think we don't mention very often, but they are stressed, extremely stressed whenever there's a baby that comes here, and it just freezes the team. So teaching them how to manage their stress, basically just take a deep breath and try to organize themselves from a crisis resource management perspective is important. So we design our simulations to be stressful, unfortunately. And we also do things all in-situ. That also came out within the needs assessment. And they want more than just NRP. They want things such as the tiny pram. They want neurological respiratory conditions, shock. They want these things a little bit different, because sometimes they find NRP is what they do often over and over and over again, and they just want to see something a bit different. Time and incentives for the participants is really important, including transport team members as faculty also, and they do also want that central website to sort of go and find out where are our protocols and what it is that we do. So the takeaway is really I hope, from my talk that I wanted to convey is that neonatal outreach is actually much easier than you think. It's a lot easier to learn than POCUS, for example. People are eager to learn. It doesn't take much money actually to get started, not at all. You do need to find your champions, however. That's probably the key. It's finding the people who are going to be working with you in your center and in other centers. And I think it's always worth studying and always worth publishing about. And I'll end on this quote, which is that you simply practice and you get better. It's very simple, from a pianist. And here's my contact information if ever you want to contact me, and we can discuss a little bit about if you have programs or suggestions. Thank you very much.